Wow. What's up with Cal? I'm mic'd, but it's very interesting that 70%. All right, folks, I think we're about ready to get started. See a few more people coming in from the doors. All right, so next up, we have Billy Wynne, who is a nationally respected health policy consultant, entrepreneur, and commentator. He's a partner with the Washington firm of Thorn Partners, where he advises Fortune 500 companies, healthcare providers, state governments, hedge funds, and other healthcare organizations related to federal policy matters. He's been featured in Health Affairs and has been quoted by the Washington Post, Politico, Inside Health Policy, and other sources. Wynne is also founder and CEO of Healthcare Lighthouse, which is a subscription-based one-stop shop for federal healthcare policy developments, including ACA implementation, new regulations, grant opportunities, think tank analysis, and press reports. Before moving to Denver, Wynne served as Health Policy Counsel to the U.S. Senate Finance Committee. There he advised committee members and drafted federal law relating to healthcare reform, Medicaid, and Medicare. Welcome, Billy.
Thank you very much, Lygia, for that generous introduction. I mean, I know I wrote it and all, but it's really, you delivered it with such vigor. It's nice. I love this conference. It is a real pleasure to be here. I love Colorado. Next week will be my 5-year anniversary living here. It's the second best decision I ever made next to marrying my wife. And the thing that I love the most about it is, not to get a little smarmy, but you're very kind, and I could just stop there, but you are also the greatest and most engaged and interesting health minds around, brought together in one of the greatest places, in my opinion, in the world. So I love coming here just about every year I can make it. And I was truly honored and flattered when the Health Foundation reached out to me and said, Billy, can you join these 3 incredibly impressive speakers as the 4th to come out and talk on the panel? And at the time, I was like, I'm so honored, so grateful. Of course I will do it. When I was sitting over there as they were speaking, that emotion began to change a little bit to, oh my God, you asked me to be the 4th speaker after 3 incredibly talented and persuasive speakers. And I'm really glad we had a break after that Cleveland Clinic video, because I mean, I had to go like bawl in the bathroom for a little while and get myself ready. Anyway, so because I'm in that slot, I'm going to try to have a little fun. I hope that's okay. And I'm going to try to be a little bit provocative. I always say that at the beginning of my talks. I don't know if it helps soften the blow, but I might say some things that hopefully provoke some feelings in you that will make this a little bit more interesting. The warning about this agenda is that I threw out 3 different ideas of what I might talk about at today when we got together, the panelists, and nobody objected to any of them, so I just said, okay, well, I guess I'll just do all 3. So it's a little bit of a grab bag, but I'm going to try to, tell a few stories and emphasize a couple of things that, we'll kind of see how it goes. I'm not going to talk on every single slide. So I am a federal healthcare policy person, so that's caveat number 3 or 4. I'm kind of a one-trick pony. I see the world through that lens, and so you're gonna get that in this talk. And so I'm going to talk a lot about how federal policy is impacting patient engagement throughout the healthcare system, including not just the delivery of care, but also getting people covered. There are a lot of provisions in the ACA that are specifically designed to promote patient engagement. These are a couple of them. I'm going to do a slide later where I'm going to make a bigger point about the ACA that I think is a little bit more interesting. But one thing I just want to note, this Patient-Centered Outcomes Research Institute, this is the body created to pursue comparative effectiveness research. There was a little bit of that going on before. This is really intended to supercharge it. This is sort of the next level beyond what the FDA does, right? The FDA, you take a product and they say, okay, this is safe and this is effective, and so you can put it on the market. But you don't, the FDA doesn't really care if it's better than the products that were out there before. Well, what comparative effectiveness research should do is say, we'll take product A and we'll take product B and we'll do head-to-head trials and we'll see which one is better. Now, there are some restrictions under the ACA. We could talk about why they're not going to look explicitly at cost effectiveness, but we're going to know what the products cost, and then we can hide that. So that's going to be in the ether. You can also look at physician intervention A and physician intervention B, and I think that's one thing. If you're not familiar with it, I would suggest kind of keeping an eye on as the ACA unfolds. Okay, I'm going to spend some time on this slide. I love talking about ACOs. I don't know about you. I think it's like, it just gets me going. It's really cool. It's kind of getting old, really, but I like telling the ACO story. So there are a couple of different programs in the Affordable Care Act that launched, ACOs with vigor. I started, like Gia mentioned, that I worked for the Senate Finance Committee. I was a young lad. I went to law school. And was at a firm, and I got this incredible opportunity to work for the Finance Committee. And the first week, I went to MedPAC, the Medicare Payment Advisory Commission. I sat down, and Dr. Elliot Fisher was sitting there going through these slides, talking about hospital referral networks. I don't think that lasted long enough to become HRNs, but he was talking about hospital referral networks. And the phenomenon was, if you looked at a community, usually centered around a hospital, and you looked at, say, hospital A and physician community practice B and nursing home C and, I don't know, diagnostic lab D, and you studied the sort of flow of patients and information, stole my punchline, but the patients between A, B, C, and D. If you're like a Martian from outer space, you'd say, wow, this is a system, right? This is operating, this is efficient, these people are moving, The joke is, of course, that those separate providers were not communicating at all. And so Dr. Fisher's idea, and others, Dr. McClellan yesterday was a thought leader on this as well, for sure. But, Dr. Fisher in some ways is credited with boosting the idea to some degree. He said, well, let's create a payment system that will incentivize provider A, B, C, and D to actually talk to each other about the patient, right? Rather than just think about, okay, I'm a doctor, I'm in the hospital, I'm gonna do this surgery, I don't know what happens, next. We're gonna communicate, and we're gonna decide, ultimately, hopefully, if it all goes well, from beginning to end, what's best, how do we get the best outcome, the patient back home living their life and doing things that they like to do. So this gets me to my definition of an accountable care organization, which a lot of people these days are saying they're an ACO. And to be an ACO, you have to do two fundamental things, I would say. One, you have to have a critical mass of primary care doctors or nurse practitioners or PAs, and I'm going to go on a tangent for a second about PAs. My wife is a PA, and my wife on Tuesday got admitted to the Dr. Andrew Weil School of Integrative Medicine at the Medical School at the University of Arizona. And I bring that up because luckily, it's a growing trend. There are a handful of these integrative medicine training programs popping up across the country. But historically, medical schools, I didn't go to one, but I hear that they don't really talk about nutrition very much. And so the Andrew Weil School of Integrative Medicine is founded on this crazy, outrageous, scientifically overwhelmingly proven fact that the food that you put in your body has an impact on your health, right? And so, but yeah, they don't teach that in medical school, I think, or at least they don't teach it enough. And so that's luckily going to be informing, I think, the future of medicine. Like I said, it's a growing trend. There's one thing that I wanted to say about food, and this is my wife talking to me, is it's good that we're starting to talk about calories, right? We're talking about the obesity epidemic, and yes, it's true. You should not eat a whole lot more calories than you need in a day, to do the things that you like to do. But there's really, of course, so much more, right, to nutrition and the kinds of things that you're putting in your body. And I think we're going to start to move into that area where we can figure out how to educate people about these fairly complex nutritional concepts in a way that they can use. One of the top ones being shopping for food, right, and reading a food label, which are not great but getting better. And this is the condensed version of how to read a food label. It goes like this: da 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 da, sugar, right? The next product, blah, 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 sugar, right? It's true, like animal protein, stuff like that may not be, probably not going to make you live longer. Sugar will kill you. Sugar will kill you. And that's another scientifically proven fact that they probably don't teach as much, in any school, which is medical school. So where was I? ACOs. Okay, so another program. Oh, the second thing you need to be an ACO. The first thing you need is a critical mass of primary care. The second thing you need is a payer who wants to pay you like you're an ACO, who wants to create that incentive structure that Dr. Fisher and others cooked up, called your shared savings, to decrease the resources you're using to take good care of your patients. You can say you're doing that, but until a payer, commercial or government, I don't care, agrees and pays you that way, then okay, you can say that you're an ACO. And by the way, big caveat for providers who think they want to be an ACO, it doesn't matter how good you were before. The clock starts when you raise your hand and somebody calls you an ACO. Because to be an ACO, you can't just stay on the path that you're going, you have to change. You have to innovate. You have to spend less, you have to use less resources than you were using before. And that's where you earn money being an ACO. I'm going to skip medical home because it's going to be here forever. Okay, just on Monday, speaking of patient engagement, so the Agency for Healthcare Research and Quality, AHRQ, put out some guide on how to engage stakeholders to promote quality of care in communities. And I was preparing for this presentation, and this was something that caught my eye. And if you look at sort of the very top line, admittedly, recommendations, it's like, well, how else would you do it, right? It's like figure out who to talk to, bring them together, right? Disseminate the information in the community, and then pay attention to the outcomes that you've achieved in your intervention in the community. But this is a major grant program at AHRQ, and it's a reminder, I think, that in some cases it's kind of getting back to basics on how to figure out how to do this stuff, but it's also, I think, an important note that this is happening at the federal level, and there's money behind it, and hopefully good things will come out of it. I said I would talk a little bit about getting people covered. If you know the difference between a navigator and a sister and a counselor, don't raise your hand. Okay, so this is kind of a ridiculous slide, right? But the point is, there's this swarm of professionals out there, in some ways created by the ACA, and then the next thing is agents and brokers, who are the fourth thing, which had kind of this whole saga of their own, but are ultimately participating and helping with enrollment and exchanges, who are learning. I mean, we have some experience, of course, with this, and really agents and brokers have been doing it the longest. But we're creating new tools. We're learning what works to get people engaged. I'm going to talk a little bit more about this in a Colorado specific context in a minute. But this is kind of an exciting time to learn how to reach people, how to persuade them that getting covered is the right thing to do. But I just wanted to note, because just this morning, in an article in the New England Journal of Medicine, actually I think it was posted yesterday afternoon, they said that 10.3 million people, this is what the authors of the article in the New England Journal said, 2.3 million people who were uninsured got insurance during the open enrollment period this year under the Affordable Care Act. Now, of course, that includes Medicaid as well, of course. But it just so happens that the number that I have in this slide is that these different federally funded assisters help 10.6 million. Now, they're not the same people, but the numbers there are fairly aligned. A lot of people got help from that new cadre of folks who are trained to help people figure out the coverage options that are best for them. I want to talk just a little bit about Medicare and Medicaid. There's a lot of assistance programs that a lot of people don't know about in Medicare if you're lower income, to help you with premiums, with your coinsurance. in the Part D prescription drug program. There are low-income assistance programs. And so there are a variety of people there with considerable funding behind their training and their execution who are tasked with the responsibility of educating consumers about these options if they need them. And this is an ongoing effort. And the White House just recently has been trying to expand. They understand how important this stuff is. They need, they say they want resources to do more of it. And again, there's oodles of lessons learned that are coming together that I'm going to get to in a second that are even playing out here in Colorado. In Medicaid and CHIP, also, again, I'm not going to read these slides to you. Hopefully they'll become available to you. I'm very happy to send them to you if you want to get in touch with me. But one thing I'll say about Medicaid and CHIP before I get to, or two things I'm going to say, before I get to the Colorado-specific stuff is, number one, CHIP reauthorization is up next year. A lot of you know that, September 20. It's not actually reauthorization. We could talk about that, but it needs to be funded beyond September of 2015. So next summer, I predict maybe we'll be having a little bit of a conversation about that. Number two is that in thinking about outreach and enrollment for Medicaid, I think it's important to keep in mind, and we're saying since I get to stand on stage and have a mic, Medicaid is a good deal for the consumer. I'm not talking about that it's an entitlement or it's a state, it's this amount of money. Like, I don't want to talk about that right now. We can talk about that. If you're a consumer and you're eligible for Medicaid, it is highly probable that it is a good deal based on the coverage that you get, the benefits that you get, the providers you have access to. Not that that is a perfect part of the equation, but it's pretty good for the price that you're going to pay out of pocket for that care. So I think it's important that people know about that. This is what I wanted to spend some time talking about. So I had the privilege, and it was a privilege, of being part of a conversation among some people who have had their boots on the ground doing outreach, trying to get people enrolled in Medicaid, in this case in the Latino community. For a variety of reasons, we got together with the regional office of the Centers for Medicare and Medicaid Services in Denver and stakeholders and various interested folks who were doing this stuff. I literally was sitting in the corner taking notes. I mean, I can't pretend to be the expert about this stuff, but I was there. And these are some of the lessons learned that came out of that conversation about things that help reach people in these communities. And some of them are fairly intuitive, but some of them were not. And there's one that I'm going to mention that is not listed here, which is it stems from this, or it's related to the lesson learned about avoiding literal translation. So some of the Spanish language materials was sort of like the Oxford English Dictionary translated to whatever this Spain's equivalent of that is. It was like not sensitive to how people actually talk in these communities. So lo and behold, that's really important. Another thing that is a little less intuitive is that a lot of people in the Latino community don't actually want to read or be spoken to in Spanish, right? And so there were people in the Latino community who were frustrated, and I think in some cases this was especially true for families who had children, for whom English was really kind of how they were learning, especially more complicated concepts. This is the way that they prefer to consume information. They couldn't actually get English language materials in their communities because everybody just assumed, that they wanted Spanish-speaking materials. And so, believe me, it's not like the people who made that decision had bad intentions, right? I mean, that's why these were lessons learned. These were people of good faith coming together. And I thought that was something that struck me as a counterintuitive thing that these people learned in the process of doing this Medicaid outreach. One other thing was tiger teams. So instead of having a bunch of people who know a little bit about everything, you have a bunch of people, each of whom knows a ton about one thing, right? So this person knows what the benefits are that you might get, right? And the other person knows where to go to get enrolled. And the other person knows, well, my child, is eligible for CHIP, but I'm not, and my employer, somebody else can help you sort out your eligibility issues based on your family status and other factors. And this group, at least, as we got together and talked about it, found that was, in many cases, more effective than just having kind of, a battalion of people who know just kind of the basics of each of those different topics. Why don't I move on? I personally am excited to hear the discussion, so I'm going to probably not use the balance of my time. This does give me a chance to talk a little bit about this ACA thing that I wanted to talk about. So there's some additional resources here. There's a lot more that I could have offered. So this is, like Gia mentioned, Healthcare Lighthouse. Last week, we had our 1-year anniversary as a startup. We're getting there. I would love it if you would go to healthcarelighthouse.com, one word, take a look, and let me know what you think. What do you hate? What do you like? Like feedback is sort of like our food right now. You know, we're in that stage. We're in our infancy. I mean, look at this site. Like, how beta does that look? You know what I mean? It's like totally not consumer free. So we're working on that. But one of the things that we have on our site is this index of the Affordable Care Act. And this really doesn't have much to do with what I'm supposed to talk about. But I don't like to miss an opportunity to say this because I don't know how many times you've heard it. I have heard it way too much. People say the Affordable Care Act is only about coverage. Have you heard that? The Affordable Care Act is only about getting people health insurance coverage. It doesn't do anything about quality, doesn't do anything about prevention, doesn't do anything about the workforce, it doesn't do anything about X, Y, and Z. Fraud and abuse, the federal program's rife with fraud and abuse. The Affordable Care Act does nothing about that. Look on the left side of that screen. Those are the 9 titles of the Affordable Care Act, okay? And granted, Title I is the premium subsidies, the exchanges, the insurance market reforms. 90% of the stuff that you read about on the front page of the New York Times is in Title I, and I think that's what people are talking about when they talk about the coverage. There's also this one provision in Title II, which is the Medicaid expansion, the role of public programs, kind of gently named for that element, but that's a big piece. But there are other pieces in there. Number 2, Title II is really primarily about Medicaid, and there are quality reforms in Medicaid. There are new pediatric quality measures for kids in CHIP. People were thinking when they wrote this law, I think a little bit more than they get credit for. Title III is primarily about Medicare, but using Medicare, the biggest payer in the land, to drive quality change in our system. If you're a hospital, it's very hard to ignore what Medicare is doing, and so that's why that accountable care organization program, that medical home program, those various things that are being instituted in Medicare, value-based, I could go on, readmissions, I think Stacy hit on a bunch of them. That is the government trying to use Medicare to drive change throughout the healthcare system, and definitely encouraging commercial payer involvement and paying very close attention to what's happening on the Medicaid side, because of course there are federal levers there. But if somebody says the Affordable Care Act doesn't do anything about prevention, just direct them to Title IV. The entire title is about prevention. If they say that doesn't, now is this the final answer? Is the Affordable Care Act solved the workforce issue? Of course, no, it has not. But please don't let anyone get away with saying that it didn't give it mind, because that's Title V. Every section in Title V relates to healthcare workforce. So I think I'm done. These are I get 2 email addresses, not just one. So I really would love to hear from you. And thank you very much for your attention. And I personally am really looking forward to the discussion with the other panelists. So thank you very much.